Hello, my name is Katie Fessler, and today is Sunday, October 6th, 2019. Today I will be presenting my Unit 2 case connections. So the first case that I chose is Case 3, and in this case we're presented with a child demonstrating frequent urination and thirst. The blood tests that we have available to us indicate that the patient likely has diabetes mellitus and does not produce enough insulin. We know this because we see that the serum levels of insulin are lower in the baby than in the control, both at baseline, which is presumably fasting, and 1 hour after the glucose load is given. This is typically the amount of time you would expect to see an appropriate insulin response, rather. We would expect this patient's fasting blood glucose levels to be above normal range. He also displays some classic symptoms of diabetes that can help confirm our diagnosis: frequent urination and thirst. Now, a little bit about the biochemical mechanisms happening that normally would happen in a patient that have to do with insulin. So insulin is produced by the beta cells of the islets of Langerhans in the pancreas. When functioning properly, these cells produce insulin in a concentration that's proportional to the concentration of glucose. We see when increased blood glucose occurs, it increases the metabolic flux through glycolysis and the citric acid cycle, which thereby increases ATP production. This increased ATP inhibits the ATP-sensitive potassium ion channels, which leads to the depolarization of the cell membrane and results in increased calcium ion influx. These calcium ions cause the exocytosis of insulin. Now, we would expect that in this baby, this mechanism does not occur properly, and it does not allow a significant amount of insulin to be exocytosed. Now, insulin has many functions. It will recruit GLUT4 transporters from the interior of the cell to the plasma membrane to facilitate glucose entering the cell from the blood, and thereby decreasing blood glucose levels and allowing glucose to become part of the metabolic pathways. Insulin negatively inhibits cyclic AMP, which is involved in glycogen metabolism. Cyclic AMP is an example of a regulatory molecule. It negatively regulates glycogen synthase and positively regulates glycogen phosphorylase. Therefore, insulin's inhibition of cyclic AMP allows glycogen to be formed and stops the breakdown of glycogen into glucose. In this patient, the lack of insulin means that cyclic AMP is not inhibited in glycogen metabolism. Therefore, glycogen phosphorylase is active, and glycogen may be broken down into glucose, further increasing blood glucose levels. Additionally, the GLUT4 receptors are not recruited to facilitate the influx of glucose from the blood into the cell. And we know that this patient likely will have high circulating blood glucose. Therefore, fructose 2,6-bisphosphate concentration is increased. This is another regulatory enzyme. It negatively regulates fructose 1,6-bisphosphatase by increasing its Km, preventing gluconeogenesis from occurring and instead allowing glycolysis to occur. The next case is Case 4. In this case, we are presented with a baby experiencing jittery spells, fasting hypoglycemia, and hepatomegaly. Of the presented options, it seems that a variant of glycogen storage disease is a likely diagnosis, but let's discuss why. The first condition given is hereditary fructose intolerance. This is caused by the absence of aldolase B, which cleaves fructose 1-phosphate. It causes profound hypoglycemia and vomiting after consumption of fructose or sucrose, which will be broken down into fructose on digestion. It will ultimately lead to fructose-induced hypoglycemia despite the presence of high glycogen reserves, like fasting hypoglycemia. It's unlikely that the baby's symptoms are caused by this. While the baby does present with hypoglycemia, the baby's only consumed breast milk. The primary carbohydrate in breast milk is lactose, which will be broken down into glucose and galactose. She's not had significant exposure to fructose to cause the symptoms that are inherent to hereditary fructose intolerance. The next option, or the next condition presented, is galactosemia. This is the inability to metabolize galactose. It's caused by an inherited defect in one of several enzymes, including galactokinase, uridyl transferase, and 4-epimerase. The unmetabolized galactose may form galactitol, which will accumulate in the lens of the eyes and cause cataracts. If the condition is the result of the defect of uridyl transferase, it will lead to an accumulation of galactose-1-phosphate, depleting the liver of inorganic phosphate and causing liver failure and mental deterioration. This description doesn't seem to fit the baby's symptoms. Our next condition that could be is glucose 6-phosphate dehydrogenase deficiency. In this condition, the deficiency in this enzyme leads to impairment of the generation of NADPH and ultimately results in hemolytic anemia when individuals with a deficiency undergo oxidative stress from infection, some drugs, or even consumption of fava beans. This occurs because NADPH is required for the reduction of oxidized glutathione. Oxidized glutathione is needed to oxidize hydrogen peroxide and to protect the cell from oxidative stress. In red blood cells, the pentose phosphate pathway is the only means for NADPH production. The lack of glucose 6-phosphate dehydrogenase stops the pathway from successfully producing NADPH, therefore leading to the hemolytic anemia. Hemolytic anemia does not fit the baby's symptoms. The final option is glycogen storage disease, or the inability to use glycogen. There are many variants of this condition caused by a deficiency in different enzymes involved in the metabolism of glycogen. Many of the variants result in some combination of fasting hypoglycemia, muscle weakness, and hepatomegaly. In this child, we know that epinephrine does not increase the blood glucose, meaning it was not able to mobilize the glucose from glycogen stores. We can presume that this is because she has a variant of the glycogen storage disease and has an inability to utilize glycogen. Her symptoms fit that of several variants of this condition. When she's consumed milk, which has a supply of glucose, she does not have hypoglycemia. It's when the glucose source is used up and she's fasting that she has the symptoms.